Thank you all for being here. To start our conversation, I really want to bring it to looking at the different factors that are affecting our mental health and how there's such a diversity of social determinants and different systems and services and everything that's influencing our mental health all the time. So, Pastor Dawn, I'll start with you. I want to start this conversation by looking at a specific sector of mental health that you can speak to that is often neglected in our conversations today, and that is rural communities. So the discourse on mental health currently is often viewed as a cosmopolitan problem or a struggle of privilege. Based on your experience as a leader in rural communities, what have you noticed about those specific mental health struggles and the factors that have influenced that?
Thanks, Julia. So before I get into, I just want to say two quick things in the interest of fairness around offering services in rural areas. First of all, I just want to acknowledge that there is a very genuine, real challenge to offer specific services to populations when you are 1,000 people spread over hundreds or even dozens of kilometers. So I just want to add a little bit just to kind of be fair. The other thing I want to say is I think we often characterize people living in rural areas as intolerant or ignorant around some of these issues. And the truth is a lot of that doesn't stem from a sense of not caring or intolerance, but more that when you have a small population, it's hard to get the resources out there, to get the education out there. And so, just to name those two things. And so I would say the two biggest things I think that hinder getting access to mental health services and that awareness, one is distance and isolation. And secondly, and probably more important, is the lack of diversity in those rural areas. And that's not just the lily-white rural areas. That's any kind of place where there's a lack of diversity. And when you've got a lack of diversity in a small population, what you end up with is you're the only one. And that makes it really hard. So another thing that happens is when services are really far away for folks. The effort to go and find out what's going on it can be really prohibitive. And so a lot of folks in rural areas are living with mental illness, but don't call it mental illness. They may have found different ways of coping. Their family or friends or their support network is finding ways to support them, but they're not calling it mental illness because they just don't have the resources to understand, to be able to use the same vocabulary. But mental illness it's not privilege. It is very present in rural areas. It just looks different than maybe what you see because so much of our education and materials are focused on the urban reality. So in my experience, I live in downtown Toronto now, but in my heart I'm a country mouse, and still most of my ministry has been in rural areas. And I would say that the big things I've dealt with people of all ages, from the age of 10 up to like 99, would be depression. A lot of that is around grief, depression, some psychosis, and also addiction is, I think, really, really high. I didn't have a chance to kind of look up all the statistics, but one of the comparisons I found that just really hurt my country mouse heart was a study done by the Canadian Institutes of Health in 2006, looking at rural health, and they found that suicide rates, and the numbers we just saw are really painful. In rural areas, suicide rates are 4.5 times higher for young men under the age of 20, and 6.5 times higher for young women under the age of 20. And so that isolation And that sense of, especially if you are LGBT, if you're the only racialized person, like anything that sets you apart makes it really difficult. And so what happens is, because we don't have the specialized therapists and the specialized people in those rural areas, or the access is really hard, the high burden really falls on the GPs, the general practitioners and nurses that are in the community, teachers, and often faith leaders like me. And so working with folks who are living with untreated mental illness and not open, or just don't have the vocabulary to be able to use that language. So we talk about a lot of other things. But I've had folks come to me about all kinds of things that I'm like, whoa, I'm way out of my depth here. But I can't just, like I can now, I can't just say, you know what, head down to Canada's preeminent mental health hospital and go and talk to a nurse there. So I do a lot of accompanying people and just kind of sitting, a lot like what we were talking, our last presenter talking about allyship, kind of sitting with people where they are. And I think that's probably one of the things that draws people to faith leaders in particular, is that most faith leaders, we lean on other resources. We lean on God. We lean on our philosophy, our tradition, to kind of just live through those moments.
Thank you. I think it's great to illustrate how often there are those gaps in services, whatever the reasons be, and we find ourselves having to figure out how to fill them with other resources. Mm-hmm. Now, I'm going to move over to you, Phillip. The conversation often talks about mental health generally, what we generally call the 5 and 5. But let's talk for a minute about specifically mental illness, or what we would refer to as the 1 and 5. Now, a lot of awareness initiatives, they generally focus the conversation on dismantling stigma, specifically about the universality of mental health and how everybody experiences it. Now, from what you've observed, how does this leave out sometimes the conversation about that 1 and 5, about the people struggling with specific mental illnesses?
So it's a good question, right? It's a complicated question. I think there's a few different things going on. So I remember, I live in Nova Scotia, but last January I was in Toronto, and I remember standing looking at the transit. I think it was in a bus shelter, or maybe on the streetcar, and seeing these slogans that, like, mental health affects us all. And I was thinking, what does that mean? Like, literally, what does it mean? Like, I'm trying to figure out what the meaning of this phrase is. And it's interesting, because yesterday I was actually talking to somebody who works at an organization where she said all of us are disability identified. And, she identifies as having a mental illness. And she said exactly the same thing. She said, I have no idea what that sentence means, right? So I think, and I've been talking to people who describe themselves as living with mental illness, I've heard kind of the same thing from a number of people over and over again. And, so one of those things is, well, we get the idea that mental illness as a phrase and as a concept is highly stigmatized. People tend to not want to put their hand up and say, I have a mental illness, right? So I guess, the positive intention of wide-scale awareness campaigns is to try to make that okay for people to say that. But the phrase mental illness remains really stigmatized, so we talk about mental health instead. But if we talk about mental health, we're conflating two different concepts, like Julia was saying before. You can have a diagnosed mental illness and your mental health can be fine, right? So we've got two different concepts we're working with, and because we might be scared of the words mental illness, and so we're just saying we all have mental health and mental health affects us all, we're actually kind of erasing the experiences of a group of people who supposedly were trying to help with these campaigns. So I think that's one of the issues. There's also the question of whose voices do we hear, and whose voices do we not hear? And why are we not hearing those voices, right? So I know, for instance, my son has said, well, I'm a pretty privileged person. I come from a fairly comfortable middle-class family, but when you have a mental illness, despite that level of privilege, you're still a marginalized person in many ways, right? But if we look at, say, for instance, my son is someone who, I don't know, I was going to say responds well to treatment, which is actually a phrase I don't like at all. But he's someone who's like, he's fine, right? He's fine. So there are people who are less well served by the system. There are people who have trouble accessing the system. One of the people I talked to for my piece that ran in the Globe and Mail said, you know, that she can go to gala fundraisers and she can wear a nice dress and she has an inspiring recovery story. And people like that, right? And she said, but meanwhile, people who are not well served by the system aren't even allowed into the room. Now, like, I don't know about you, but when I walked in the front door today, I walked around somebody who was sleeping in a cardboard box, right? So I don't know if that person has mental illness or not, but we do know that a very large percentage of people who are homeless or home insecure have mental illness, right? And I thought, okay, like, obviously, as an individual right now, there's nothing really I can do, but there's clearly an irony that I'm stepping around this person to walk into this nice building to participate in this conversation, right?
I think that's such a valuable point in that we are putting so much energy into this movement, but we have to make sure the movement includes everyone, even if it's not just the easy parts, right? Like, we don't fully understand some of these specific mental illnesses, but that doesn't mean we don't include them in the conversation. So I'm so happy you're here today to share that. Now I'll transition over to Gursharan. So to change the focus a little bit, we talked about the specific distinction of mental illness. Of course, there are other distinctions within the realm, within the landscape, to use our language of today. Within the landscape of mental health, there's specific distinctions such as culture, language, ethnicity. So that's what I would like you to speak to, specifically. Amongst this national narrative that, as we've kind of touched on, can often be generic and generalized, what unique challenges have you witnessed, specifically in the landscape for South Asian women?
So when I kind of think of this question, for me the starting point really is how many immigrant communities and racialized communities experience mental health disparities. So we know in Canada that new immigrants to the country, when they first arrive, are actually doing a lot better than Canadian-born residents. But over a period of time, around 5 years, the mental health and physical health of new immigrants actually worsens. And then flipping over to belonging to a racialized community, there's evidence, really compelling evidence actually coming out of the States that's showing that racism hurts and has an impact on the development of chronic mental health and physical health issues. So if we think of that as the kind of overarching narrative experience that young South Asian women are growing up in, there's already kind of certain vulnerabilities there. When we look at the data globally, we know that young South Asian women actually experience higher rates of suicide and self-harm. So I'm thinking back to the slide that you showed actually around suicide, and I wonder what the stats are here in Canada. Unfortunately, we're a bit behind in terms of how we've been collecting race and ethnicity data here, so we're not fully able to kind of slice and dice the data that way. I, for the last couple of years, have been leading some work that's focused on young South Asian women. It's called the Roshni Project. Through this kind of multi-phase project, we've been able to really learn more about the mental health of young South Asian women here in the GTA. We heard about the role of family and the collective stigma. So, we've talked a bit about stigma on the panel already, but even kind of thinking through how stigma manifests differently in different communities. And for the women that I've been working with, it's most definitely in a more kind of collective way. Thinking about intersectionality and multiple kind of marginalized identities, gender, race, ethnicity, sexual orientation. The more kind of marginalized identities that the young women were identifying with, the greater the stigma, first of all, and then the kind of poor access to inclusive spaces for them to actually heal. Gosh, I have so many things to say. Different understandings of mental health. A number of South Asian communities actually talk about well-being and healing in a very holistic approach. Mind, body, and spirit is connected. And this is very different to the Western biomedical model. So in our qualitative study, actually, so these were Canadian-born South Asian women, talked about these holistic approaches that they had engaged in their recovery journey. The pressure of belonging to an immigrant community. So parents often saying to their children, we've sacrificed everything in our home country to come and provide you with a better life, essentially, and really putting a focus on education. A number of the participants that I've kind of worked with, and clients that I see as well, really struggle when they're at school. There are expectations of young South Asians, not just women, but men as well, to go into certain professions, and that really going against their grain, so to speak. So there are a number of factors there. The other kind of last piece that came out of the work that we're still doing is for young women struggling to navigate their identity during adolescence. So the home environment still being a very traditional space, but kind of outside at school and university and so on being a very, very different type of life. So there are all these factors that these young women have navigated through. Many of them actually struggle to access formal support, often seeking out peer support. The few that have been able to connect with more formal mental health supports talked about what then happened when they met with a clinician or a social worker or a psychiatrist and feeling quite judged. Many assumptions being made about their culture, rather than taking that more kind of curious, humble stance in terms of learning about somebody's culture, and then kind of going on from there, the availability of culturally relevant treatments and interventions and so on. There's a really cool video that we made. We've actually made a series of 4 films, short films, and one of them focuses on the mental health sector. And actually, Jack.org's very own Jessie Bra wrote the spoken word piece for that short film, and it really illustrates some of the challenges that the young women experience when accessing services.
Nice. One thing I'll add to that I remember from our conversation that we had earlier that I found particularly eye-opening for me as someone who isn't on a day-to-day basis facing these issues. You spoke before about the collectivist nature of these societies and how there becomes an additional pressure put on like the family's reputation and such. You can probably better speak to it than me, so if you wanted to do that.
I think I remember the example that I gave as well. Yes. So when we think about stigma, it does manifest differently across different cultures. The South Asian culture, this is might sound like a generalization, but it's pretty accurate, operates from a very much like a we stance. So rather than stigma being located in the individual, it's often the kind of family unit. In one of the studies that I worked on, I was working with a South Asian woman that was experiencing psychosis, and for a number of years, so from the age of about 16, 17, and she was well into her kind of late 20s at this point. And she talked about how her parents and her siblings, like her family, wouldn't let her out of the home, essentially, and interact with her community and so on. And the family, in particular, kind of her parents had said to her that, we want to limit your interactions because we worry that your illness will impact your sister's marital prospects. So when we think about stigma, I mean, that might sound like a really subtle thing, but that's the collective. So it's how does the stigma kind of affect the unit? Yeah.
I know for me, when you first told that to me, I found it very eye-opening because it shows that different cultures have these different experiences, both of mental health and of the stigma associated with it. Now, to bring the conversation back to you, Pastor Don, I do want to talk more about systems, as we have been speaking in Jack.org a lot more about systems change these days. Often the focus is on services, specifically formal health services, but we're learning more and more that there's different social determinants and informal services that do have such a big role to play. So my question for you, as a religious leader, what can you tell us about the influence of faith, both as an institution and as a source of community?
So I think most of what I'm going to talk about is, I think, some of the great ways that all faith traditions, not just Christianity, can contribute in a positive way to be part of the support. Before I do that, I just need to acknowledge that, and I'll speak for my own tradition, that the Christian tradition has also, the slide earlier about factors of oppression, when religion was up there, I was like, so are we a force of oppression or a factor that brings oppression? Because we have been both. And I know what's coming out of the States right now, the Southern Baptist Church, the Roman Catholic Church, it's happened in Canada too. And I represent an institution that was one of the largest providers of residential schools, the Anglican Church of Canada. So I just want to say, I want to acknowledge that, and to say if that kind of abuse has touched you from the Christian church or from a faith tradition, I am sorry. I am really sorry. And if you need to hear that from someone one-on-one, you can find me after. That being said, for every from every story, for every incident of hurt and oppression that happens from faith traditions, there are hundreds of not only pastors, but just faithful people in this country who, because of the tradition or the philosophy they follow, are trying to make their communities and the world a better place, and to help people who are vulnerable. One of the things that is really great about faith communities is you walk into whatever building is in your community, you are going to find basically a microcosm of your community. You will find in my church, I have got, and my church is like, it's in Toronto, but it's tiny. I get like 15 or 20 people on Sunday morning. But we have got queer folks, we've got racialized people, we have like 1-year-olds up to 94-year-olds, we have 4 different languages being spoken. So one of the things that we do really well is build bridges in order to build community. And so, and I think that's really valuable right now in such an image-driven society, and especially as we begin to own our identities. It's really tempting and sometimes safer, but there's also a temptation to just hang out with people of our own identity. So those kind of multi-generational, multiracial, multilingual spaces, I think, are really great. We also advocate for folks in our communities. We work around, I do a lot of work in my chaplaincy work is a lot of work around mental health, and my community is involved in that as well. And we have part of being that kind of community, and I know that faith communities aren't unique in this, any kind of community, we know how to take care of each other. So one of the examples I used is, someone, when there's a crisis in a community, especially if you're in a small town or rural area, say there's a house fire. While we're waiting for the Red Cross and the government to get their way out there, the church ladies have all gotten together and they've collected all the blankets and they've made casseroles, and they're there, and the people already have a place to stay. So I think we can do better, but we can do that around mental health as well. Supporting people who are grieving, helping to curb that sense of isolation that leads to so many addictions and so on. I think finally I just want to talk about that advocacy piece and social justice. We are, particularly as the church, there are churches all across this country who are doing their part to make the world a better place. And and mental health, any kind of services, we're there. We're there with you. And I would say, as advocates, as these chapters in your communities, I would recommend reach out to your local faith community. Ask them if you can speak. I will give up. Hey, any Sunday I don't have to preach is awesome, because preaching is a lot of work. So if you want to come and preach at my church, just give me a call. And you don't have to be able to talk about the Bible. Just come and tell your story. And those are great places to find support for the really valuable, important work that you're doing.
Thank you so much. Now, I do feel like this is the perfect time to bring in one of the questions that I'm seeing on the poll everywhere. If it looks like I'm looking at the ground, I promise I'm not. There's a screen here, so it's helping me out. So the question is about the LGBTQ plus community and how there generally has been some resistance from the church. And I know that you are generally a supporter and an advocate for this community, so what I hear from the audience is we're wondering what resistance you faced, and I'm wondering too how you've pushed through that.
Yeah. First of all, I have to. I've been looking at that question too, and gulp. So I have to say that for all the resistance that I faced, there is equal or more support. And for that, I eternally give thanks. So the resistance I have faced as an advocate and an ally, it's, I think on a personal level, the resistance that really hurts is that I get characterized as someone who doesn't take the Bible seriously, or who doesn't take my tradition seriously. And I have to say that really hurts, because my commitment to equality is rooted in gospel principles. My commitment to helping folks who are oppressed comes straight from the example of Jesus Christ. And it has always been part of my tradition. So that's just the personal part that hurts. I think the thing that really shocks me about the resistance I face is the real violence behind it. And that's not violence directed towards me in particular. But I was at the Anglican Church of Canada gathered in 3 years ago. We're gathering again to talk about the same stuff about same-sex marriage. And, the people who spoke out, there's lots of ways that one could talk about exclusive male-female marriage that do not condemn people to hell, that you don't have to clench your fists and shout, but they didn't. The rage that was behind that agenda was really frightening. And we are meeting again 3 years later to do the same thing, and that violence has never been acknowledged by our system. So I think part of my role as an ally is to enter into those conversations that just are not safe, and the language my community uses is the queer community, that it's just not safe for them. So I can sit down with somebody who has a different interpretation of Scripture, and I can have that conversation on a theological level. I can speak that language, and I can listen as people, because people are shifting is the other thing in our church. And people are wrestling with really important questions about how do I love my child? How do I, how do I reconcile this with what I've been taught by my religion? So as an ally, I can go into those spaces and have those really important conversations. Yeah.
I want to say honestly thank you on behalf of myself, but I'm sure others in this audience, for being that ally within an institution that has caused a lot of anxiety, as is the same with government, with educational institutions, where we often hear about those negative experiences, and it's very refreshing and hopeful to hear that there are people on our side who ultimately have common goals, and it's just a matter of how can we get there. So thank you for that.
Thank you for that.
Now, I do want to bring the conversation back to Phillip because I have a question that I've been waiting to ask. So your article, one thing that it specifically speaks to is how the focus in our work is often, and when I say our, I don't mean just Jack.org, I mean in general, the government, schools, everything, is often focused on attitudes or knowledge around mental health. And in your article, you say how sometimes this is not effective at bringing about the behavioral change that we need in order to tangibly provide services and change the discourse. So from that, I'm wondering, what to you is lacking in these current initiatives? What needs to change? And then also, what's your reflection on initiatives that have been shown to work, such as the peer-to-peer empowerment that we do through Jack.org, which we've seen to cause more youth to reach out for help. So if you want to share your reflections on that. I know it's a long question, so just say what you want.
So yeah, big questions. I guess I want to start by saying, like, I'm not an academic researcher, and so I've read a certain amount of what's out there in terms of the research, but I'm not an expert in this subject. So my experience is based on what people have told me, either through interviews or reaching out to me to share their stories and experiences, and what I have read in a variety of journals as well. And if in terms of that kind of thing, if there, I have things that I'm wrong about or whatever, feel free to jump in. But I think, from my reading on the effectiveness of large-scale mental health awareness campaigns, and I find it's interesting because people often will say to me, "Oh, I read your Bell Let's Talk story," and so really my point was not just about Bell Let's Talk. There are lots of other campaigns by lots of other organizations. It just happens this is the best known one, and they happen in other countries as well. I think in the UK there's a campaign called Time to Talk, which is similar in its approach. So from what I've read in the academic research is that you tend to see after one of these campaigns is run a certain kind of bump in awareness. So people will, if they're asked a series of questions about, how aware are you about the prevalence of mental illness? Or would you be more likely to recognize signs of mental illness? Or do you have an understanding that mental illness can be treated? So a lot of those things will show a little bump, like, okay, so there is some success. One of the issues is if you go back and resurvey those people, you'll often find that over a period of time, that bump disappears. Or it may not fully disappear, but largely disappears. And when you ask questions around behavior, how would you feel about having a coworker with mental illness, or dating or marrying someone with mental illness, you don't really see any change. So when it comes to behavioral approaches or behavioral results, you don't really tend to see those. I wish I could remember who told me this, but I do remember somebody saying, like, I don't care what you think about me, I just care about how you treat me, right? Now, I do think on some level, generally we do care what people think about us, but I thought it was a very striking statement, right? You had more than one part to your question, and I don't remember both parts.
I do. One of the parts I had mentioned was, what's your response to specific initiatives that have been more effective?
So, from what I've read, the more effective interventions or more effective campaigns seem to be ones that work on a more specific audience, often youth and students, and that have contact with people who identify as having a lived experience of mental illness. So in those cases, when we have people who are willing to share their stories in a kind of genuine setting, I think, and have a back and forth in conversation, that does tend to have a better effect in terms of changing people's attitudes and in terms of greater understanding. I can tell you a story about myself. Like, so I used to be a student at Concordia University in Montreal. I knew nothing like about mental illness or, I think I had like, I'd read a certain amount. I had a kind of vague idea of like psychiatry as bad. They're just kind of like categorizing people who are different and marginalizing them. And so one day I got a sandwich and I sat down on a bench and I had my book bag beside me. And this guy came to sit down on the bench and I picked up my bag and moved it. And he said to me, "Don't worry, I'm not going to steal your stuff." And I was like, "Oh, I'm not worried about you stealing my stuff. I just thought I'm just making space so you can sit down," right? So then we wound up talking for like an hour. And he was the first person I met who identified as having schizophrenia. And he had like incredible insight into the workings of his mind, right? So we had a great conversation. And now I wouldn't say that it changed my life because like whatever number of years, 20 years later or something, when I was going to the early psychosis clinic in Nova Scotia with one of my kids. I really had no idea about what early psychosis was. But definitely it had an effect to me having this conversation with this guy who turns out is also called Phil. And also, coincidentally, years later, I was hired to do some writing related to a documentary film, and the documentary was actually about this guy, and it was made by his brother. So as I was watching the film, I was like, oh, this is the guy I had the conversation with on the bench. So I do think that those one-on-ones definitely make a difference. Also, because of the stigma, I live in a rural community. It's not a remote community. We're only like 40 minutes from downtown Halifax, but it's definitely a rural community. There's miles of forest behind my house. There's no transit. And there's a real mix of, people who've lived there for generations and fished, people who have a lot of money who've built big houses on the coast. And so I know that when we first became involved in talking about my family's experience with the mental health system, or you would just kind of find, because people are, even though we're not far from Halifax, there is a certain amount of isolation, and you would get like somebody coming up to you in the superstore, which is our Loblaws, is the Atlantic Superstore, and go like, "Oh, my kid knows your kid, and I think my kid is kind of going through some of the same stuff your kid is, but I haven't talked about that with anybody." And we wound up having these conversations like over and over again. Or I'd walk into a family support group meeting and, "Oh, there's someone I know." And we're kind of looking at each other like, "Oh, you're here." And, because you don't feel that kind of safety to share those experiences. So I do think like there is definitely a value in these smaller scale, maybe, but not broader. Many smaller scale interventions, it's my sense, are probably more effective than big, large, let's feel good about sharing stories of our mental health.
I think that's a good reflection. What I really hear from that is, okay, awareness is important, having positive attitudes is important, but it comes down to how do we treat individuals and how do we treat these individuals as valuable human beings? Because what I'm hearing from this conversation is individuals who are struggling, their struggles aren't just diverse, their struggles are each also diversely valuable. And I think that's a big part of truly understanding mental health, is understanding the value within these people that we otherwise might just label as struggling. Now, I do have one last question for Dr. Gursharan over there. So let me just use my papers because I tend to forget things. So again, shifting to the question of cultural and ethnic diversity. So not only does our mental health system not always address the specific cultural needs, but often our conversations aren't super inclusive of the multicultural country that we live in. So I'm wondering, how do we make mental health change more inclusive for immigrants with different cultural needs, including the many international students that I'm sure a lot of us share our campuses with?
2 words: representation and co-creation. If there's anything that I've learned in my career and belonging to an immigrant community also, voices matter, diverse voices matter. I'm just thinking about, Bell Let's Talk. I was so happy, and so were many of the youth that I work with, that last year Bell Let's Talk were clearly engaging a more diverse, more representative group of people that reflect Canada, which was great if you have access to mainstream media and so on. You go to the heart of Brampton, which is where I live, or Scarborough. Bell Let's Talk doesn't filter its way through to every community, and I'm sure that's not just for kind of racialized and immigrant communities too. But if diverse voices aren't included in the conversation, are we being inclusive? How do we create that social change? And that leads me to my second kind of point around co-creation. Are we making an effort to actually reach out and make sure that people that are included in these conversations, if we're leading them, are representative? I see that as my responsibility as a clinician, as a researcher, and thinking of representation and co-creation throughout the process, right? So who's involved in research? Whose voices are being represented? When I kind of think about developing interventions and so on, is our sample diverse? Is it reflective of the communities that we're serving? Kind of the co-creation model became so much more kind of at the forefront of my thinking through the Roshni project, so the work that I did with young South Asian women. And through that project, the young women went on to develop these 4 short films and tip sheets. They were their voices. And we've seen the really organic impact of those voices filter their way through communities across the GTA, because I think the message really resonated with the South Asian community because it was coming from within. We just provided the space, essentially, for that to happen. So representation and co-creation, I think we need to think about that through various steps of creating that change.
I think those are both such good points. Now, in the interest of time and the limits of time, we will have to be wrapping things up, but I just want to say, overarching, I think what we've really been hearing from today is there's such a diversity of experiences, and specifically there's a diversity of voices that we need to be listening to, and not just listening to, but we need to be understanding them, and we need to be addressing them and acknowledging them. And so now it's a matter of figuring out, okay, how can we make our services and the support we give more diverse and more accessible to all, and also accommodating the different pathways that people are on and can take, whether it be seeking support through faith, whether it be specific supports for specific mental illnesses, whether it be needing to understand the cultural implications and influences. So above all else, thank you to all of you for coming. Again, I don't want to speak for everyone, but I think I'm not the only one who is very thankful that we had such a diverse group on stage today. I don't know about you, but I don't think I've been in the room with a pastor, a journalist, and a psychologist at the same time before. Yeah, it sounds like the start of one of those jokes, totally. But as we know, mental health is not a joke, and these are important conversations and interesting conversations, valuable conversations that we're going to be continuing all weekend. We've looked now at what the mental health landscape is like, what challenges exist, and so in the next 2 days, we'll be looking at what can we do about it. And so I hope this inspired some thought in all of you. And again, thank you, Pastor Dawn, Phillip, Gursharan. Your voices are so important. And with that, I am going to conclude this panel, and we'll move on to our next activity. But thank you all, and thank you to the audience for joining in this conversation.